Hello, I'm your host, Dr. Warren Seigel, and welcome to 26 Minutes with Dr. Seigel on the Zurmed Show. On the show, we will feature local physicians and healthcare leaders who are experts in their respective fields and who will share their experiences and their wisdom. We will cover a broad range of health-related topics on the show, and today we have Dr. Jeff Goldberg of South Brooklyn Health. Dr. Goldberg, thank you so much for joining us today.
I'm very happy to be here and talk to you.
So I've known you for many, many years, and besides the fact that you're a huge tennis fan, tell us a little bit about yourself.
I was actually, born and raised here in Brooklyn, in South Brooklyn. I went to high school not far from here at Lafayette High School, and then I went on to Columbia College for my undergraduate degree, and I'm actually in the first graduating class of the NYIT College of Osteopathic Medicine in 1981.
That's wonderful. So it's a local boy done good. That's great. So tell us a little bit about what your practice is. What kind of doctor are you?
Well, I'm an adult board-certified psychiatrist. I have a subspecialty in geriatric psychiatry as well, and I've been practicing for over 40 years in the field.
So when you talk about psychiatry, this is actually National Suicide Prevention Month. Can you explain why is suicide such a difficult diagnosis to make? Where does psychiatry fit in? Tell us a little bit more about suicide.
Well, it's very important to talk about it and have a conversation about it and spread awareness about suicide. If we don't talk about it and get it out in the open and publicize it, it becomes more mysterious, and people feel more hopeless about doing anything about it. Actually, worldwide, there are about 800,000 suicides each year. In the United States, there are 50,000. That is someone dying by suicide every 11 minutes here in the United States. So we have to talk about it. It's an unmet public health need.
That's incredible. 50,000 people
Just
in this country.
Nearly, right.
And 800,000 worldwide. So,
and the suicide rate has risen, over the past 20 years.
Why is that? Do we have an understanding of why more people turn to suicide?
I think it's very complex. Why that is, and many factors go into that in terms of economic factors, social factors, untreated and unmet treatment of mental illness, and access to mental illness. All these factors go into it. Plus the demands of a very fast-paced, internet-connected, online society. So there's a lot of different influences out there on social media that can contribute in a negative way.
I know you mentioned that you are an adult psychiatrist, and this particular area of expertise is geriatrics, or older adults. Are there particular age groups of people that are more at risk for suicide?
So that's a very good question. There are actually three groups that we're concerned with, and the group over 75 years of age is at higher risk for suicide. The very young, I know you're an adolescent medicine specialist, so that group especially, and the young adults, so 15 to 24 is a higher risk group, and the middle age group, say 45 to the mid to late 50s, is a group where we see certain peaks and increase in suicide attempts and suicides.
Wow, that's incredible. So basically you're saying 15 to 25, 45 to 55, and over 75, that doesn't leave a lot of us around who are not at risk. Are there certain other risk factors besides age that would put people at higher risk for suicide?
I think one of the areas we look at are people that are exposed and have history of violence in their lives. So someone who's the victim of child abuse, someone who's the victim of sexual abuse, someone who might have been in the past or currently a victim of bullying. These are things that could be contributory.
Wow. Seems like there aren't many people that aren't affected. What about those of us who are concerned about our friends or our family? Are there protective factors that we could say this is something we can do to help them and keep them from committing suicide?
Well, people, what we look to in protective factors, we think about people that are connected. If you're part of a support group, if you have a very supportive family, if you belong to a religion and you are connected through your local church or synagogue and have that connection. If you have reasons for living, if you have children, so we consider that a protective factor. But not that these protective factors absolutely guarantee that you wouldn't experience suicide or suicidal behavior.
So what's the role of someone's primary care doctor? Where does a doctor fit into all this? If I'm feeling down, I'm feeling blue, I'm depressed, I'm isolated, what should I do?
So, that's an excellent question, because what we've discovered is people that have gone on and died by suicide have actually seen or had contact with their primary care doctor within the past 30 days prior to dying by suicide. So there's an opportunity there when you go see your local and regular doctor to talk about and be screened for depression and other factors that may reveal to the doctor that that you're at risk for suicide. But at the same time, there's a lot of stigma surrounding suicide, and people feel that if they share this with a doctor or someone that makes them inadequate or weak, and even feeling depressed and suicidal, someone may still want to get the approval of their doctor, and they don't want to be. They may feel judged in a negative way, so they may hold back and not share those thoughts.
You mentioned screening. What does that mean, screening?
So screening is you need to actually ask the question, and you start by screening for depression, for instance. You ask about a person's mood. Have they been feeling sad or hopeless? You ask about how you're sleeping. What's the appetite like? Have you lost interest in things that used to give you pleasure? And have you had a lack of energy? These kind of things point to depression as a possible condition and low mood. And if you screen for depression, part of that screening is, have you had thoughts about killing yourself? And you actually have to use those words. You can't mince around and you say, well, have you thought about hurting yourself? You actually have to use the words, ask, have you thought about killing yourself?
So you're suggesting that when somebody sees their primary care doctor, their doctor asks those questions, and do we really believe that people say yes to any of those?
Well, you'd be surprised. I mean, if you're in a doctor-patient relationship and you feel comfortable and you trust your doctor and that may be the opportunity, the time when you don't, don't hold it back, but share that information with the doctor. So I think part of it is to feel comfortable and to trust the doctor. It doesn't even have to be the doctor. It can be a family member, someone close to you, a loved one. Mm-hmm. People say, what could I do to prevent suicide among a loved one or someone I care for? And Warren, there are five action steps that can be done. The first thing is to ask, are you having thoughts? Are you thinking about killing yourself? And the second thing is to keep them safe. And what does that mean? That means to actually, if you know that they have lethal means in the house, a loaded gun, medications, anything that obviously could be used to hurt themselves, you want to remove that. And then the third thing is to be there, right? To be there to talk to them, to listen, and not judge. People who are feeling suicidal, I think that's what holds them back, is that they're going to be judged in a negative way. You want to be there as a friend or a doctor or a loved one and be there for them. And then the third thing is to connect them to help, right? It could be through 988, which we could talk about a little bit more. That's a crisis lifeline, or connect them to a mental health professional. And then the final thing is, even after you've done all that, is to stay connected with them. And we found this very interesting. Just the mere fact of a phone call, an email, a text, even a postcard to someone who's been feeling suicidal somehow contributes to them preventing them from going on to commit suicide.
This is really helpful. So one thing I'm hearing is that suicide is a lot more common than we think it is. And what I'm hearing you say is that screening for depression actually decreases the likelihood that somebody is going to commit suicide. So we're not really treating their depression, we're actually just looking for them to be suicidal, or are we trying to get them help while they're depressed?
So some people have said, well, we should make suicide a diagnosis, but actually, suicide is really a symptom of depression and illness. So we really want to get to the underlying causes, the underlying factors that are there. Often when someone is feeling suicidal, they have a kind of tunnel vision, right? And they don't see a way out. They don't see any other type of solution to their problem. And the only way they could relieve themselves from the pain in their experience is to end their life. And what we're trying to do is just to make that connection and keep them going and show them that there is alternative, that there is hope. And often that passes. That someone who's acutely suicidal is really a matter of time, and there are treatments also where that will pass, and then there'll be alternatives.
So you mentioned 988. I think you
right.
said that's a telephone number that people can call. Just dial 988.
So think of 988 as the mental health equivalent to 911, right? It's a dedicated emergency telephone crisis line. And with 988, you could actually text, you could talk, online, and you could even have chat. It even connects you to chatting online. So whatever means you feel comfortable can be accessed through the 988 network. This is something that was started in actually 2001, and it's taken us, where are we, 2023? It's taken us virtually 22 years to get it to the point where now it's being connected and being put into systems in cities and states all over the country. It's the mental health equivalent to 911, and that's really in an emergency, and otherwise it's the first step toward making that connection and getting help.
So when you talk about emergency, are you saying I should call 988 when I'm I've decided to kill myself, or is
Well-
988 the place I should go to get referred if I'm depressed?
It's both. It could work for both. If someone is experiencing acute suicidal thoughts and feels that they want to end their life, either themselves or a loved one could call 988, on their behalf, or the person themselves could call 988 and reach out to a crisis counselor, and they will keep you on the line and talk to you and connect with you and get help for you. But also, if you experience any type of mental health crisis, 988 is a first step. It's an avenue. If you don't know anyone, or if there isn't any other way of connecting you to a mental health professional.
So what I've heard so far is, one is that depression is pretty common, suicide is clearly very, very common, and we want to keep that from happening. I heard you say that all of our doctors, and I shouldn't just think about doctors, I should think about our PAs, physician assistants, nurse practitioners, all of our healthcare providers should be screening everybody for depression and helping those people get into treatment. Are there treatments that are available to everyone regardless of their ability to pay and their insurance status? Is this something that everybody has access to?
So, yes, depression, suicidal thoughts, feeling hopeless, helpless, all of these conditions and situations have means to treat them and address them, and people can come out of that type of crisis. In terms of what you were saying about the screening by PAs, by all pediatricians, primary care doctors, there are standard instruments that we have in the profession that are geared to help those professionals screen for depression and suicidality, and the treatments that are available, to everyone from all walks of life. Now, what could those treatments be? There are certain therapies that we use in psychiatry and in the mental health profession, cognitive behavioral therapy, to get someone to rethink about their ideas about themselves and their life in a different way, help reshape their thinking. Again, that takes time. There's also medication that we use, the antidepressant medications that we have in the field that are also used by primary care doctors and psychiatry, are very effective in addressing depression. And when the depression leaves, suicidal thoughts and thinking also lifts. So.
I remember a patient of mine many, many years ago who was clearly depressed, and I wanted to refer them to a psychiatrist. And they went to the psychiatrist, and the psychiatrist said, "I want to see you every week for the next 6 months." And the patient said, 6 months, that's too long. And he said to the patient, "Well, how long have you been depressed?" And the patient said, "Oh, about 10 years. He said, 6 months compared to 10 years, there's no comparison. When I think of going to a psychiatrist, is this something I've got to do for the rest of my life? Is this a medication I have to take the rest of my life? Or are there things that I can get help with much faster?
I think it's hard to generalize. I think each patient, each situation is different. Some people will require longer care and longer follow-up. Others not so. A lot of factors again contribute. Also in terms of think about family history, family support. If you were the victim of trauma, if there are long-standing issues, versus someone that may have been very fine, and then suddenly they experience a loss, in a job, or some blow to their self-esteem. If suddenly they're recently widowed or divorced, that could be an issue. Or if they're experiencing later in life chronic pain, or chronic illness. It really depends on their situation in terms of how long and what they will need in terms of their mental health care.
So it sounds like therapy is individualized, depends on who you are, what your family history is, what your long-standing history of depression is. This TV show is about being healthy. Are there things that you can suggest as a psychiatrist that we can incorporate into our lives to be less depressed, less suicidal, more healthy from a mental health standpoint?
It's the things that you hear and are told by doctors and in the public, and we hear it all the time about the basic things that we need to take care of ourselves in terms of our diet, our sleep, and our exercise. And you'd be amazed. I often tell my patients, in terms of antidepressant, the best antidepressant is regular exercise, and if you could do that either through regular walking, and they talk about it, having a certain number of steps each day, or regular running, or treadmill, but to do that on a regular basis. It releases the natural endorphins and enkephalins in our body, and the natural antidepressants, and it reduces anxiety and reduces depression. And of course, with the regular exercise, is getting that adequate hours of sleep, and eating healthy diet. It's those things actually are really the bedrocks of physical health and mental health.
So it sounds really interesting that physical health is so connected to our mental health, and our mental health is connected to our physical health. We just came through the pandemic where so many of us, quite honestly, were depressed. We were lonely. We were isolated. Some of us just spent too much time with our families, which could be depressing for some people. Some of us just spend too much time at work, which can get depressing. What do you say to people who are concerned about their loved ones, besides calling 988? If I have a loved one that I'm worried about, what can I do?
Well, I think the key thing is to listen to them. Often, a loved one or someone that even we're very close with might say, that they're feeling depressed, or they don't like themselves anymore, or something to that effect. And very often I'll hear, with patients or families that I'll see, that the response from them is, "Oh, just snap out of it," or "Oh, how could you feel that way? You have everything to live for," and that kind of sort of snap judgment or response, I think isn't really what's called for. It's really the answer to your question is to really listen with an open mind and not be judgmental. To ask the person to tell me more about what you're going through, and if the sense that they get is that you want to hear them and want to listen to them and not be judgmental, then they'll open up and tell you more, and then we could figure out together what are the next steps.
Sounds like that feeling of connection that
Right.
you talked about, whether it's with your church, your synagogue, or your mosque. Making that connection
I think
is
you
really
hit,
important.
I think you hit the nail on the head there.
Yeah.
I mean, the antidote to depression and suicidality, in many respects, is connection.
Yeah.
Connection, is the thing that we want. I think when you're in that frame of mind where, if you're depressed and suicidal, you've shut everyone out, you've withdrawn, you're missing that connection.
So you mentioned earlier that one of your specialties is geriatrics, the older population. What do you say to those of us who are getting there, those of us who know people who unfortunately don't have friends or family around, are there programs to help them to be healthier from a physical standpoint as well as mental health?
Right. So, in my practice, I see, several patients who, over 75 with depression. And I see the thing that helps them when we get back to connection is they go and to community centers, right? To different centers where there are activities, where there are groups. Some of these patients, are they as you said, are by themselves. That they're either widowed or divorced. Relatives are all over the country, and they feel lonely. And despite the fact of giving them and treating them for depression and medication, the added ingredient is getting them to be connected in a community center type of activity that's geared to that population.
Great advice, and thank you so much, Dr. Goldberg. And thank you for your interest in our show and your desire to become involved and educated. I invite all of you to visit our website, www.zurmed.com, and check out our tools and connect with us on our social media. You can also call us at 718-510-2103. Please stay well, be safe, and thank you for tuning in. Goodbye.